that we are building on our discussion, that we are using our discussion effectively to build something?
It's exactly actually the kind of questions that I would like to ask in the debate, because I do not want with whatever will be discussed to be only a one-way decision. I am here to facilitate, to coordinate to whatever people and to attend to whatever people would like to do. So this is something that I want to dive in deeper during the debate, because we have discussed a lot and we have also. Bonjour, est-ce que la réunion se fera uniquement en anglais? Non, la réunion se fera en anglais et en français, je ferai la traduction. Sorry, somebody was asking me if we were going to be doing it only in English, so I just had to let them know that we'll do the translation as well. So this is something that I want to dive into. So this is something that I want to dive into. I hear myself. Sorry, I could hear myself twice, so I had to cut that. So I didn't hear myself twice. So this is, so I like the fact that you actually asked this question, because it's something that I would like to dive deeper during the debate, because we talked a lot about cooperation. We talked a lot about seeing what are the capabilities of Africa, trying to see what kind of actions we can do. And I do not want to be the only one decided. I would like actually to hear from all the panelists and everyone here to see what we can do next. So, so this is my answer for now, because I have like an idea that I'm actually working on, but once it is completely well done, I will present it. Now I gotta have it well prepared. But I'm open to hear what are your thoughts, Dr. Safwat, obviously. Okay, Dr. Judalbay has joined us, so I just hope his internet is well, and if it is, we will start the session and the other panelists will join us on the way.
Allô?
Oui, on vous entend là.
Vous m'entendez? Je suis obligé de me connecter de mon téléphone. Je ne sais pas qu'est-ce qui arrive à mon internet à la maison là. Ça complètement déclenche. Donc là, je me connecte au téléphone. Donc, ben, je vais rester connecté sur le téléphone alors.
Vous êtes aussi à 10.
Pardon?
Parce que Dr Beyene, qui est aussi, donc qui est du ministère de la Santé d'Éthiopie, a aussi eu un problème d'Internet. Je pense que c'est un problème en Éthiopie en ce moment.
Ça doit être un problème au niveau d'Addis Abeba, donc. Parce que là, je ne sais pas du tout ce qui se passe. Depuis ce matin, je me bats, j'essaie de me connecter partout là, mais bon, j'ai du mal. Donc, bon, je garde la connexion sur le téléphone.
Dr Beyene a le même problème. Si vous voyez, elle vient de se déconnecter. Je vais lui dire d'essayer d'utiliser son téléphone parce qu'elle a aussi un problème.
Je vais rester connecté sur le téléphone. Comme ça, malheureusement, je ne pourrais pas mettre la vidéo pour essayer d'avoir suffisamment de bandes là pour pouvoir...
De toutes les façons, voilà. J'ai votre présentation. Donc, je pourrais partager votre présentation en anglais. Comme ça, vous n'aurez pas...
D'accord, ok. Voilà, vous partagez ma présentation en anglais et puis moi, je parlerai en français. Donc, il n'y a pas de souci. Okay.
Très bien, on va faire comme ça. Je vais juste dire à Dr Beyene, I understand.
Avidan?
Okay. Hi, Dr. Beyene. Again, I know apparently you have a problem in Addis Abeba because Dr. Judalbay is well in Addis Abeba, so he has some problem. He's with his phone, so apparently it works better. But I think we will start the session right now so that we make the most of the internet. Bonjour à tous, désolé pour ce petit retard. Nos panélistes ont un problème de réseau, donc on fait avec. So thank you again for everyone for joining us today. So we have with us today Dr. Hamedi, who is Director of Health Emergency and High Prevalence Diseases at the Ministry of Health of Algeria. We have also Dr. Sinead Bayer, who's Senior Advisor to the Ministry of Health of Ethiopia. Dr. Safwat, who's an international healthcare quality consultant and board member of the Egyptian General Authority of Healthcare Accreditation and Regulation called GAHAR. And we also have Dr. Benjamin Duvalder, who is the head of policy and communication at the Africa CDC. Bonjour à tous, bienvenue à notre dernière séance des Africa Healthcare Webinar. Aujourd'hui, on a avec nous Dr. Hamadi, qui est la sous-directrice des maladies prévalentes et alertes sanitaires au niveau du ministère de la Santé de l'Algérie. On a Dr. Senaïd Beyer, qui est conseillère pour la ministre de la Santé d'Éthiopie. Dr. Ahmed Safwat, un consultant international en qualité des soins et aussi membre du conseil d'administration de l'autorité générale égyptienne d'accréditation et de réglementation des soins de santé. Et Dr. Benjamin Dudalbay, qui est directeur de la diplomatie et des politiques de santé au niveau de l'Africa CDC, qui est donc l'agence africaine pour les maladies. Thank you so much. So before we start with this session today, I just wanted briefly to summarize a little bit what has been discussed in the last two sessions, what we will be discussing today, and then we will move to the presentation and our panelists. Donc avant que l'on commence la séance, je vais juste brièvement faire un petit rappel de ce qui a été discuté lors des deux dernières séances que l'on a eues, et ainsi que présenter le programme d'aujourd'hui. Can you see my screen? Can you see the screen? Okay. So just a quick reminder of what we're going to be discussing today. So we already had two sessions, as mentioned before. Here we go. So today we're going to be touching upon two important topics, one of them being clinical audit, how to develop a specific audit tool for COVID-19 that will be presented by Dr. Safwat. And therefore, after that, we're going to be talking about deconfinement strategies and economic recovery in a post-pandemic. So we will hear also from the different countries to tell us what is their strategies of deconfinement. And this presentation with recommendation from the Africa CDC will be done by Dr. Benjamin Dudalbay. After that, we'll be mostly going into Q&A and debate, and as Dr. Safwat has mentioned in the beginning, discussing what can be done, what kind of action, what will be the follow-up of this initiative. Donc aujourd'hui, nous allons parler de deux points importants. Le premier qui est donc la question d'audit clinique, comment développer un outil spécifique pour la COVID-19, qui sera présenté par Dr. Ahmed Safwat. Puis, on va parler de stratégie de déconfinement et reprise économique dans une post-pandémie. Cette présentation présentera les recommandations de l'Africa CDC, sera faite par Dr. Benjamin Dudalbay. Nous allons aussi avoir chacun des pays présents qui vont nous parler rapidement de leur stratégie de déconfinement. Puis, on va passer à des questions-réponses et le débat pour vraiment voir comment avancer ensemble et comment continuer dans cette initiative de collaboration africaine. So just a quick reminder, what I want to do is just to remind what we were talking about in the first session. So the first session was on the 13th of June, where we were talking about surge capacity and the role of e-health. So we obviously have the conclusions, and the discussion was longer than just those 4 points, but I just wanted to give a quick overview of what has been discussed, such as the importance of having an emergency strategy in place in each country that will be able to be deployed within 48 to 70 hours, and that we have to adapt to the realities in each of the healthcare system of the specific countries. Donc, avant de commencer, je voulais juste faire un petit point de ce qui avait été discuté. Donc, notre première séance avait eu lieu le 13 juin dernier, où on avait parlé donc de préparation du système de santé et de e-santé. Bien, on a fait des conclusions qui sont bien plus longues que ces 4 petits points, mais je voulais juste rappeler les points les plus importants qui avaient été discutés. Le premier, par exemple, était l'importance d'avoir une stratégie d'urgence en place dans chaque pays qui répondrait notamment à la réalité de chacun des systèmes de santé, mais qui pourrait être déployé sous 48 à 72 heures dans des situations de ce genre. The second point we were talking about was having a clear national strategy and policy to make sure not to waste the resources or duplicate them or actually go against what is done. So really having a real coordination. Le deuxième point dont on avait discuté, c'était l'importance d'avoir une politique et une stratégie nationale claire d'utiliser les ressources disponibles de manière optimale, d'avoir une réelle coordination pour éviter de dupliquer des actions ou d'avoir des actions qui allaient à l'encontre les unes des autres. The third point we're discussing was like the importance to invest in human resources and to tackle all the aspects of whether training or also mental health. Those were kind of some of the points we discussed. Le troisième point, on avait parlé notamment de l'importance d'investir dans les ressources humaines et le personnel de santé, que ce soit en question de formation, d'accompagnement, de gestion de la santé mentale, notamment en période d'épidémie et de pandémie. And the fourth point was, for example, we need to invest and think thoroughly on the question of management of change, because we were talking about technology with e-health or such capacity of going into emergency states, so making sure how to make sure that practitioners and the population adhere to that, and the importance of communication. L'autre point que nous en avions discuté, c'était le besoin d'investir et vraiment de réfléchir sur la question de gestion du changement, que ce soit de la part des médecins, de la population, l'importance de la communication pour s'assurer que la population et les différents acteurs adhèrent à la politique qui est mise en place. The second session was last week. We were talking about vaccines and health monitoring. Donc, la deuxième séance, c'était samedi dernier, où on parlait de gestion de veille sanitaire et de vaccins. One of the points that was very important that is kind of the point that we've been discussing since the beginning of this webinar is really the importance to have an African initiative, African cooperation, and really when it came to research and development or even vaccine, but really the importance of working together for all the healthcare system to have a healthcare system adapted to the African realities. So really pushing even more the cooperation that we have on the continent. Donc le point dont on avait discuté, qui est vraiment la ligne directrice qui est un petit peu de ces webinaires, c'était vraiment ce besoin, cette importance d'avoir une coopération et partenariat au niveau africain et l'importance d'avoir cette initiative africaine, une initiative africaine pour réellement travailler ensemble pour répondre aux besoins, aux réalités africaines et d'adapter les systèmes de santé par rapport à ça. The second point was really the importance to be prepared for epidemic and pandemic, whether on the question of hospital readiness, training, research, infrastructure, as communicable diseases are a reality in the future and in our healthcare system nowadays. So this is something that we cannot wait or just be as an action, but really be prepared. L'autre point dont on avait discuté, c'était l'importance de se préparer en cas d'épidémie et de pandémie, étant donné que les maladies transmissibles sont toujours une réalité, elles n'ont pas disparu, elles vont continuer. Donc vraiment l'importance d'avoir les hôpitaux qui soient prêts pour traiter, pour savoir comment gérer des maladies transmissibles, la formation, la recherche, les infrastructures qu'on a en place. The third point was also the importance of strengthening the existing healthcare system on the points of policies, reform, funding, infrastructure, and human resources, as we need to be prepared to have like preparedness and response measures to both pandemic and not pandemic. Because even though we've been talking about COVID-19, we do know that we do have still other diseases such as malaria or non-communicable diseases that are still the realities in our healthcare system that we still need to tackle, and we need to reinforce that. L'autre point dont on avait discuté, c'était vraiment le renforcement des systèmes de santé existants, que ce soit sur le point politique, financement, infrastructure, ressources humaines, et vraiment s'assurer de toujours avoir cet équilibre et cette importance entre gérer les pandémies ou les épidémies et les maladies qui continuent à exister, que ce soit les maladies non transmissibles ou transmissibles qu'on a en réalité sur notre continent. The last thing that I wanted to mention and to actually just give an overview, those are the data as of this morning from Africa CDC on the reality of COVID-19. As you can see, the biggest cases still are, well, Morocco now has joined us. We have Egypt, Algeria, Nigeria, Ghana, Cameroon, South Africa are the one with most of the cases. So this is just to give an overview of the reality of COVID-19 today on the African continent. Donc là, je voulais juste donner un petit aperçu de ce qu'il en était pour la Covid-19 en Afrique. Donc là, vous pouvez voir que les pays les plus touchés aujourd'hui avec le plus de cas sont le Maroc, l'Algérie, l'Égypte, le Ghana, le Ghana, le Cameroun, le Nigeria et l'Afrique du Sud. Donc là, c'était vraiment pour donner un aperçu pour savoir où est-ce qu'on en était sur le continent lorsqu'on parlait de Covid-19. So this was just to kind of remind everyone what we have been discussing about what are the realities today. Right now, I just want to give a short time for all our speakers. We will start with Dr.
Hier, tu n'as pas décroché, je suis à une visioconférence. Voilà. Visioconférence.
We have also Dr.
Donc, je te rappelle dès que je finis.
From Ivory Coast, so he's the one doing the session. So we have also Ivory Coast with us. Bonjour, Dr. Bliri. J'espère que vous allez bien. So we're just going to be quickly starting, and I will give like 3-4 minutes to each of you just to give us quickly what is the strategy on deconfinement that the countries are thinking of putting in place, so that after we can go right after to the presentation of Dr. Safwat. Dr. Hamadi, we will start with this. On va juste rapidement faire un petit tour de table avec nos participants pour avoir une idée. Bonjour Dr. Machiaoui, je ne voyais pas tout le monde. Pour savoir ce qu'il en est, quelle est la stratégie de déconfinement choisie dans chacun des pays. Dr. Hamadi, je vous laisse la parole, 3-4 minutes.
Oui, merci beaucoup, merci Shiraz, bonjour tout le monde. Comme il y a le professeur Mahiaoui qui est avec nous, je suis ravie qu'il soit là. Le professeur Mahiaoui qui est membre du comité scientifique chargé de suivi de l'épidémie en Algérie. Donc, je lui donne plutôt à lui la parole parce que moi, j'ai parlé assez les deux précédentes séances et donc il est là pour répondre à ça. Merci.
So we have Dr. Mahiaoui, who is part of the scientific committee here in Algeria when it comes to COVID-19. So he will be telling us about the deconfinement. So just to give you a little bit of an idea, he is part of the he's Chief of Service of Reanimation here in Algeria and part of the scientific committee. Docteur Mahiaoui, voilà, si vous avez juste brièvement, si vous pouvez nous dire quelle est la stratégie de déconfinement qui a été choisie par l'Algérie, qui va être mise en place pour que l'on puisse avoir une petite idée. Vous pouvez le faire en français, je fais la traduction en anglais, ou vous faites en anglais, je fais la traduction en français, c'est au choix, ne vous inquiétez pas.
Merci beaucoup, bienvenue, je salue tous les invités, welcome everybody. C'est une initiative louable pour essayer d'échanger un peu et on remercie les organisateurs et Dr Hamadi qui a assisté pour que je participe, d'autant plus que je vais avoir un programme chargé, donc je dois me libérer rapidement. Néanmoins, je pense qu'on a essayé de réfléchir par rapport aux expériences de tous les pays, des recommandations et des orientations de l'OMS pour pouvoir proposer un plan de déconfinement progressif premièrement, et région par région, et selon des critères bien définis, tels que éventuellement le R0 dans les différentes wilayas. Et on a classé les wilayas en 3 types de wilayas, les wilayas à haut risque, les wilayas à moyen risque et les wilayas à bas risque. Donc, dans les wilayas où le R0 est inférieur à 1, le pouvoir de contagion n'est pas avéré élevé, où les structures de santé ne sont pas dépassées, où les enquêtes épidémiologiques se font de façon effective, donc la situation est maîtrisée. Donc pourquoi et bien entendu, la chose la plus importante, c'est que dans ces régions, toutes les mesures barrières sont appliquées aussi bien dans les hôpitaux que dans la communauté, parce qu'en réalité, ce qu'on a remarqué, que tout a été fait au plan politique.
Allez-y, je l'ai mis sur mieux.
Tout a été fait au plan politique, au plan décision politique, tout a été fait au plan sanitaire, l'organisation, la mise en place, les protocoles médicaux, les stocks de médicaments, les EPI, les trucs de protection individuelle, etc. Tout est disponible, mais il y a un déficit au plan communautaire. Comme l'a signalé l'Organisation mondiale de la santé, ce qui reste à faire, c'est au plan communautaire. C'est bien de donner des orientations, des organisations et prendre des décisions, mais à condition que tout cela soit suivi de façon effective au niveau de la communauté. Donc, le travail actuellement et la responsabilité actuellement est dans le niveau communautaire. En Algérie, certaines régions telles que les wilayas à l'est ont marqué une recrudescence du nombre de cas par jour. Hier, on a eu le plus haut taux de de cas par jour. On a eu 240, on n'a jamais atteint ce. Effectivement, là, on a installé, à la demande du président de la République, on a installé une cellule opérationnelle d'enquête épidémiologique qui va aller sur place pour essayer d'augmenter un peu les capacités de ces enquêtes épidémiologiques, de voir sur place est-ce que les moyens logistiques et les moyens humains répondent et quels sont les résultats de cette enquête épidémiologique pour pouvoir endiguer éventuellement les différentes zones un peu chaudes ou qui sont à haut risque. En gros, voilà ce qui a été proposé comme mesure de déconfinement.
Parfait. Merci beaucoup. So when it comes to Algeria, so as we have 48 regions in the country, so they have been separated or actually categorized into like high, medium, and low regions in regards to the contagious of the region, the structures, the status of the different infrastructures, and also the different measures and needs that have been put in place. So there is a policy plan that has been put in place when it comes to protocol, healthcare, stock protection. So everything has been thought through, and they actually looked at what the WHO also was recommending. However, the main focus right now is really on communication and community and having the community adhering to this. Because we could see right now in Algeria that we have an increase of number of cases. Yesterday, we have one of the highest number of cases, 240, which was the highest we had. And this is why now what they have put in place as well is an investigation cell to actually understand why, to try to see what are the logistical means that can be put in place and to make sure to decrease this number and not have an increase of number of contagious cases. And this actually happens in the east of the country. Perfect. I will give Dr. Beyeni. Oui, Dr. Hamadi, vous voulez rajouter quelque chose?
Oui, merci beaucoup. C'est juste, merci professeur Mahiaoui. Je voulais juste rajouter quelque chose par rapport à la stratégie mise en place pour le déconfinement. Professeur Mahiaoui, c'est le comité qui font les recommandations pour les autorités par rapport à la stratégie de déconfinement. Mais dans cette stratégie, il y a la mise en place des protocoles sanitaires. Donc, c'est des protocoles par secteur et il y a les mesures générales et les mesures spécifiques. Je tiens à le préciser. Il y a aussi des critères de reconfinement. C'est-à-dire que même s'il y a un on laisse besoin, si nécessaire, si besoin est, de reconfiner aussi la wilaya ou la région. Voilà, merci.
Merci. So quickly, quick thing that also Dr. Hamadi wanted to add is that there is a healthcare protocol that is in general put in place for the entire country, but there are also some others that are more specific per sector. And there is also some criteria. There is possibility to actually be confined again or having a lockdown again, depending on the different data that they receive. So although we might start deconfining in some regions, it doesn't mean that we won't be reconfining again. Merci beaucoup, Dr. Hamadi. Je donne la parole à Dr. Senaïd Beyen pour qu'elle nous dise ce qu'il en est en Éthiopie. Dr. Beyeni, so if you could let us know what is the status when it comes to the confinement in Ethiopia,
please. Thank you so much. Good afternoon, everybody. So when we came to Ethiopia, we're still in the upward curve of our pandemic. We didn't basically had a lockdown even initially. We had an state of emergency instated. But it is a kind of a little bit looser state of emergency, not a very strict lockdown that we had in place. However, we're still in a state of emergency, which is going to be ending by the end of July. However, we're planning to actually make it more strict because now we're actually having cases more and more, and the pandemic is basically expanding in Ethiopia. So with the state of emergency, what we did is we tried to actually avoid clubs, restaurants, cross-border travelers, Even between regions, travels across the regions, travels were actually prohibited, or actually not exactly prohibited, but we discouraged the travel among the regions and cross borders, and we had also no international flights and everything, and the land borders were closed. But again, that was not even that also was not a strict lockdown and a strict state of emergency. But now, since we have confirmed there is a widespread community transmission right now, we are planning on to strengthen the state of emergency by having a compact strategy where we actually have a strong, a widespread testing, including also antibody testing and case detection, isolation, and treatment, so that we contain it before we actually have a shoot in the epidemic. Thank you.
Ok, perfect. Thank you so much. Donc, Dr Beyeni nous expliquait que en Éthiopie, ils n'avaient pas mis en place donc de couvre-feu ou de confinement strict en tant que tel, mais ils avaient annoncé donc l'état d'urgence sanitaire dans le pays, qui devrait finir à la fin du mois de juillet, mais ils planifient de le faire beaucoup plus strict au vu de l'augmentation des cas dans le pays et que la pandémie continue de se répandre. Ce qu'ils avaient commencé, c'était par éviter tout ce qui était club, restaurant, tout ce qui est place publique et rassemblement public, ainsi que tous les voyages transfrontaliers. Là, ils ont un plan national, mais qui est beaucoup plus focalisé et qui vont refaire tout ce qui est question de tests, d'isolation et de traitement. Donc voilà, donc là, ils sont beaucoup plus sur un effort de lutte contre la pandémie et on n'est pas encore sur la question du confinement. Parfait. Thank you so much, Dr. Beyeni. Dr. Safwat, could you tell us quickly when it comes to the confinement in Egypt, please?
Actually, let me take all my speech to my presentation. I would prefer that. It would be better.
That's fine. That's fine. We have also with us Dr. Franck Simon Bléry. Dr. Bléry, si vous pourriez nous dire un petit peu ce qu'il en est, la situation en Côte d'Ivoire. So we have Dr. Bléry. I'm going to see if he can unmute himself to tell us the situation in Ivory Coast. Dr. Bléry. But today we have a bit of internet problems, so. Okay. Dr. Bléry? Okay, so I think we're just going to move forward, and if afterwards he wants to intervene, we will do so that because I don't see him unmuting himself. So I think we're just going to move forward with you, Dr. Safwat, so we can talk about the clinical audit, and we will still have him afterwards if you want to talk during the debate or in the questions. Okay. Donc, comme Dr. Bléry, je ne vous entends pas, donc je pense qu'on va donner la parole à Dr. Safwat. On va continuer avec le programme. Donc, s'il y a quoi que ce soit, après, vous pourrez, après la présentation, vous pourriez dire quelque chose. Dr. Safwat? Ah, here we go. I thought I lost you as well.
Hello, can you hear me?
Yes, I can hear. So just to let you know for the translation, I would not be translating every sentence. I will give just like the main takeaways by the end of the presentation in French. Donc juste pour les personnes qui ne sont pas anglophones, je ferai une traduction des idées principales de chacune des présentations à la fin de la présentation. So after this PowerPoint, I will take the main takeaways. Okay?
Okay.
Oh, we have Dr. Oladijo Johnson from Nigeria, so I will have them talk afterwards about the confinement in their countries. Go ahead, Dr. Safwat.
Okay, good afternoon, everybody. I'm very pleased to be with you again and to hear and learn from all of you again. As just a recapping of what we started since the first session, I started talking about how to have a strategy for preparedness, healthcare system strategy. Then we went deeper to have hospital preparedness. Then now we are gonna talk about, are we really sure that we are doing the right thing? Are we providing the right care? Is there any way, any means to make sure that we are doing what we are supposed to do to get what we are supposed to get, or just assumptions? Are you there, Shiraz? Because I'm gonna go next after this. I'll
Yes,
stop
sir.
before every next.
Docteur Safwat était en train d'expliquer. Donc, la première séance, on avait parlé donc, de préparation en fait, du système de santé, après la préparation des hôpitaux. Et puis, l'idée d'aujourd'hui, c'est vraiment de voir comment s'assurer que l'on est vraiment en train de procurer donc, les soins qu'il faut, les soins nécessaires, et ce que l'on est censé offrir donc, au système de santé. Go ahead.
So let us see these figures. We have figures. I just captured these figures from Egypt and from overall the world about confirmed cases, recovered cases, and deaths. Can we have clear explanation, for example, about why the confirmed cases is such figure here and such figure there? It's about infection only, or it's about documentation, or about diagnoses? We use the right diagnoses or not, or the right way of documentation or not. This is about the confirmed case. Again, for the recovery, why this number is recovered already, this number of patients? Did we do the right care? And what is the right care? How we define the right care? So what about the deaths? Why they died? They died because we did well, but their case was severe, or we did not do what we were supposed to do. Can you explain, have you any clues in your minds how to explain these figures? I'm here not talking about a specific explanation. I'm talking about, can we have a tool to explain these figures?
Do you want them to answer that?
Yes, if you have suggestions or recommendations from the panelists or from participants, I'll be glad to hear.
Perfect. Donc, on a une question là de docteur Safwat qui explique donc comment est-ce que l'on peut interpréter ces chiffres, comment est-ce que ces chiffres sont donnés, que ce soit le nombre de cas, le nombre de morts, qu'est-ce qui explique que l'on a ces chiffres-là? Dr. Beyeni, Dr. Ladijo, Dr. Blahiri, Dr. Hamadi, would you like to share your thoughts about it or how it is done in your countries? Can you explain? If you want, you can just raise your hand and you unmute yourself and you can just share your thoughts. Let me know.
Hello?
Hello, Dr. Ladijo.
Yes, I'm just joining now. Can you tell me what you said you are discussing? I just joined now.
Yes, no worries. So we just started with the presentation of Dr. Safwat. So we will be talking about clinical audit. So he was explaining, how we started when we started working with him. The first session we were talking about strategy preparedness, and we're talking about hospital preparedness, and now we just want to see how we are really providing the right care. So the question right now is, when we're looking at the number of confirmed or recovered or deaths, when we look at those numbers, how can we explain those numbers? Is it a question of diagnosis? How are we sure about the right confirmed cases? How do you assess those numbers in your country, pretty much? So,
Okay. Thank you very much. In my own country, what we did was to have a case definition that actually explains what community transmission is all about. Because initially we were actually looking at the imported cases, but after some time we realized that we cannot really say this is imported, because most of the imported cases have mixed with the community. So from the community case definition, we're able to have a definition on INI, that is influenza-like illness, as well as a SARI, that is severe acute respiratory infection. So we look at the hospital record, and if we have any of those cases there, then we test for that case. Then we now do contact tracing of those cases, and then we actually evacuate them to the treatment center where we have care. But we realize that we are now having so many cases that are confirmed, and if the treatment center cannot really take them, and they are mild, that is, the cases are mild, then we take them to isolation center. Isolation center is like a hotel in quotes with case managers manning them. So these are the ways we actually manage these cases, because the cases are rising every day, you know. So it has not really come down. So we need to start expanding our treatment center as well as our isolation center. So we have what we call triage, you know, knowing that this one, they have a very mild illness, and those ones that have severe illnesses, we take them to teaching hospital where we have a special ward for them. And then all the specialists are actually, you know, looking after them. So these are the ways we actually look at the confirmed cases and treat them accordingly. Thank you.
Okay, thank you very much, Dr. Aladijo. I'm just going to do a quick translation, Dr. Safwat, and then you can just continue. Donc, Dr. Aladijo, qui est du Nigeria CDC, qui est en fait responsable, juste pour donner, il est responsable en fait de l'alerte sanitaire au niveau de l'agence du Nigeria. Donc, expliquer qu'au Nigeria, pour déterminer les différents cas, il s'appuie sur les données des hôpitaux pour savoir ceux qui ont été admis et quel est en fait leur état par rapport à la Covid-19, si ce sont des cas sérieux ou bien non, et en fait ils font un suivi par rapport à ça. C'est comme ça qu'ils ont les différentes données. Okay, Dr. Safwat, would you like to continue?
Okay, I forgot where I stopped. Okay.
So you were talking about the data
and trying to remember where I was talking. Okay, as just fast recapping to remind even myself that we started from very high level strategy, then operational preparedness, hospital, and now we are asking how to make sure that we are doing what we are supposed to do. Are we providing the right care? And if we are providing the right care, are we getting the right result or the right outcome or not? Here, the answer, the only valid answer here is the clinical auditing. Clinical auditing is a unique process. It's not like the ordinary auditing or the regular auditing. Clinical audit is a quality improvement cycle that involves measurement of the effectiveness of healthcare. Here, we are actually measuring the effectiveness of healthcare against agreed or proven standards. And these agreed or proven standards can be something international, or it can be national for high quality, and not only measuring and taking action to bring practice in line with these standards so as to improve the quality of care and health outcomes. So to make sure that we are doing what we're supposed to do to get what we're supposed to get, we need first to measure, then to recognize the gap. If we have gap, then to fill the gap. This simply, what about the clinical audit before I go to the details how to perform a clinical audit? Shiraz?
Sure. Donc là, docteur Safouad donnait la définition donc, de l'audit clinique. C'est comment s'assurer que l'on a les bonnes mesures pour s'assurer de l'efficacité ou alors des manques dans l'aspect clinique du système de santé. Voilà.
Okay, here if we go through the clinical audit cycle, which I've just mentioned now in the definition, we will identify the issue, what we want to audit clinically. For example, we want to audit Corona, COVID-19 management. We want to audit certain certain condition like sepsis, like myocardial infarction, like treatment of cancers. It can be clinical condition, or it can be certain clinical pathway or service. We can audit clinically the care in ICU, in emergency departments, in hemodialysis, and etc. Then after deciding what issue we want to audit, we'll go to the second stage. Here, to be able to follow with me, here we are coming to the second stage. Here is to obtain or define standards. And here is also another very, very critical point, because to measure treatment or to measure management of COVID-19, for example, or myocardial infarction or sepsis, etc., we need to have a standard to measure against. So how to develop these standards and how detailed these standards are supposed to be? This is another issue. And here, let me tell you something about some tricks of clinical audit, which is very important here and critical. Clinical audit generally can be classified by many ways. One of them is it temporary process or permanent process? For example, now we have pandemic for coronaviruses or COVID-19 infection, so we can have temporary program for 6 months, for 1 year, to measure dealing with this pandemic, because this pandemic will not be sustained forever. But if I'm a system like Ministry of Health of any country, and I want to make sure that I have most of my data is coming from stroke, myocardial infarction, sepsis, and I want to make sure that I want to keep my eyes all the time that am I treating them according to the standards or not? I'm talking about clinical care. I'm not talking about any other things. I'm giving the right medications, the right dose, at the right time, doing the right procedures by the right people or not. This is another type. So we have this temporary and we have the permanent. Then we'll go, whenever you want to interrupt me, Shiraz, to translate, you can interrupt me, because this slide will spend most of the presentation on this slide.
So we'll stop for now, and I'll start with what you were already talking. Donc, je vais juste faire la traduction de ce qu'il expliquait déjà ici, Dr Safouad. Donc, la question d'audit. Donc, en soi, que déjà l'audit clinique peut être fait sur n'importe quel service ou n'importe quelle institution. L'idée, c'est vraiment de comprendre, d'identifier le problème que l'on a et d'identifier ce que l'on veut régler, qu'est-ce que l'on veut savoir et comment détailler cela. Là, on est, donc par exemple, quand on identifie le problème, aujourd'hui, cela peut être par exemple la Covid-19. Maintenant, on veut obtenir ou définir quels sont ces standards. Donc, on est à l'étape numéro 2. Et en plus, ce qu'il faut savoir pour toutes ces questions d'audit clinique, c'est que cela peut être soit permanent, soit temporaire. Ça, par exemple, temporaire, cela peut être au niveau de la pandémie de la Covid-19, vu que de toutes les façons, cela ne va pas être sur le long terme. Donc, comment est-ce que l'on va s'assurer qu'on est en train de donner les bons traitements? Mais en-delà de cela, mis à part pour la Covid-19, l'audit clinique peut être fait à n'importe quel moment, vu que l'important, c'est de savoir si l'on est en train de traiter avec les bons standards. On parle de standards cliniques et standards de soins. Go ahead.
So, this is the first time that we are having this permanent or just temporary. And again, it can be detailed or according to very few number of standards. And I will show you examples for this and for that. And also it can be just national audit system all over the country, or it can be local at the level of the organization only. The organization is facing a problem in treating certain condition, so they are auditing this treatment locally within the same organization.
Donc, ils expliquent qu'en fait, l'audit peut être soit national, soit local. Cela peut être selon les besoins, savoir si l'on est en train de donner les bons traitements, les bons standards. Donc, cela dépend réellement du besoin des systèmes de santé.
Okay, but the main point we need all the time to keep our eyes on. Clinical auditing is mainly about process and outcome. It can measure some standards related to structure, but this is not the area of focus there. Mainly we are measuring the process, what we are doing, and the outcome, what we are getting.
Donc, ce qui est très important, c'est que quand on parle d'audit clinique, on est vraiment en train de se focaliser sur les process, donc qu'est-ce que l'on fait, et les résultats. Quel a été le résultat de ce que l'on met en place? On n'est pas en train de parler d'infrastructure, mais vraiment du process en lui-même.
Then we'll go to the third stage. We decided what we need to measure. Then we'll go to the third stage, which is collecting the data. Collecting the data we need to prepare the collecting data forms, then to teach the people how to use it, either manually or automated. We have two choices according to the preparedness of the system. Then we decide about the population size. We'll collect for all related cases, or we will have sampling. And if we decided to have sampling, we need to decide the way of sampling and sampling size. It's going to be randomized or stratified randomized or guided or by convenience. We need to decide about it, and every case has its own criteria to decide.
Donc là, après avoir identifié le problème, défini les standards, on passe à la partie collecte des données. Donc, il faut à la fois préparer les formulaires, former les personnes pour savoir comment les utiliser, quelle est la population, la taille de la population qui va être auditée, et aussi la manière dont cela va être fait. Est-ce qu'on va voir chaque cas ou est-ce qu'on va voir de manière générale? Donc là, c'est vraiment tout le process de la collecte de données.
The most important point here, who is gonna collect the data? Usually for national clinical auditing, of course, for local clinical auditing, it will be done totally by the organization itself, by the hospital itself, by the primary healthcare center itself. But for the national clinical auditing, usually it's done by two levels of data collection. The first level is done by self-auditing by the same organization. And the second level is done by the national authority for validation and verification of what was collected already.
Donc, le point important, c'est de savoir qui va faire la collecte de données. Bien sûr, on commence par l'organisation et l'infrastructure de soins primaires qui, elle, va collecter les données. Après, quand on est au niveau national, il y a deux choses. Il y a un audit qui est fait par les infrastructures, mais aussi par les autorités nationales qui s'occupent de tout ce qui est réglementation. Go ahead.
Okay, then we'll come to the fourth step here, which is very critical step. And this is the decision-making step. Compare the performance. Here we need to answer on the question or on the coming questions. The first question, did we do what we are supposed to do? If the answer is yes, this is good. If the answer is no, so what is the gap between what we did and what we were supposed to do? This is the first question.
Donc la première question. Sorry, I'll start with question by question. So, la première question qu'on se pose, c'est déjà de savoir quel est donc entre ce que l'on était censé faire et le résultat, quel est l'écart que l'on voit dans cela. Second question.
The second question is, okay, did we get the result we are supposed, the impact of the process, the outcome? Did we get what we were supposed to get or not?
La deuxième question, c'est de savoir si on a eu l'impact que l'on désirait, le résultat que l'on souhaitait ou non.
And here you will find us having two situations for everything. For example, we have done what we are supposed to do, but and we get what we're supposed to get. This is one option. The other option, we have done what we were supposed to do. We did the right care, but we did not get the right outcome.
Donc là, on se retrouve sur deux scénarios possibles. Un, on a fait ce qu'on était censé faire et on a eu le résultat que l'on souhaitait. Ou alors, le deuxième chose, c'est qu'on a fait ce qu'on était censé faire, mais on n'a pas eu le résultat escompté.
And also the reverse. We did not give the right care, but we get good outcome, or we did not get the right care and we did not get the right outcome. So this is the two possibilities for every question.
Et la deuxième, c'est aussi pareil, c'est qu'on n'a pas fait ce qu'on était supposé faire et on n'a pas eu aussi le résultat qui était escompté, ou alors on n'a pas fait ce qu'on était censé faire, donc le process, mais on a eu ce que l'on attendait comme résultat.
Because this is gonna affect the fifth step of implementing the change or filling the gap.
Et cela, en fait, va vraiment avoir un impact sur l'implémentation du changement que l'on veut avoir et l'impact que l'on souhaite avoir.
Let me give you the coming scenarios. The first scenario, and please Shiraz, translate scenario by scenario.
Okay.
The first scenario, we did what we are supposed to do according to the data collected. We did what we are supposed to do. We did the right care, but we did not get the right outcome. So the possibilities here are two possibilities. Either the data or the information is wrong or fake or false. We did not do the right care. That's why we did not get the right outcome. Or the standards of right care which we are following are not giving us the good outcome. So if we are doing, again, in the first case, if this is fake, we need to review our data collection. If the standards are not, we need to change the standards.
Donc, dans le premier scénario que l'on va avoir, c'est on a fait ce qu'on était censé faire au vu des données que l'on a eues et on a donné donc les soins qui étaient censés être, mais on n'a pas eu le bon résultat. Donc là, cela veut dire deux choses. Que un, soit la donnée est fausse ou elle est erronée, soit que les standards de soins que l'on a mis en place ne donnent pas les bons résultats. Donc là, ça veut dire qu'on va devoir revoir la collection des données, ou alors il faut qu'on revoie et qu'on change les standards de soins qui ont été mis en place. Okay.
And here, after implementing the change, if according to what we decided already, we decided to sometimes it is just to educate the people or to change the standards or to give him or to give them more supply or more resources. They do not have it, so they are not able to follow the standards. According to in the fifth step, we are gonna implement the change. After implementing the change, we will gonna go here to the sixth and final step of re-auditing to make sure that our change have impacted already the outcome and the process. Of course, positively.
Donc là, quand on a choisi quel est le changement que l'on devait faire, que l'on devait mettre en place, ce que l'on va faire, c'est que l'on va re-auditer, réévaluer ce qui a été mis en place, les changements, pour s'assurer que, comme on a dit à la base, on fait ce qu'on est censé faire et on a le résultat escompté.
Okay, here I just want to give you some clues about how to develop clinical care standards. According to the Australian Commission, the clinical care standard is supposed to be small number to be able to collect data about it, but critical small number to describe the care the patient should be afforded and it should be offered, and it can be according about clinical condition or defined clinical pathway. This in case of that we are dealing with sustained clinical auditing. But if we are measuring temporary, for example, for COVID-19 and want to measure, are we doing what we are supposed to do? It needs to be detailed auditing, and I'm going to show you an example for that.
Donc, pour le développement des standards de clinique, donc, comme clinique, il faut mettre en place un petit nombre donc, de données, de références qui doivent expliquer ce qui peut être mis en place. Par contre, quand on va sur quelque chose de temporaire, donc là, on doit aller beaucoup plus dans le détail de ce qui doit être mis en place, par exemple pour la Covid-19. Et là, il va nous donner un exemple par rapport à ça.
Okay, right now I'm gonna stop share this file and I will start to show you examples of what I've mentioned. Can you see this one?
Yes, we can see it.
Great. This is the Australian Commission of Safety and Equality in Healthcare. This is an example for clinical care standards of acute stroke. If you remember when I said it's a small critical number of the standards we need to follow. So they put only 7 standards to do that, and they call it quality statement. The first one.
Sorry, I'm just going to explain the how. So,
okay.
Comme il expliquait, donc c'est quelques nombres, donc quelques références, quelques outils. Donc là, ils en ont choisi 7, et donc il va nous expliquer ces 7 points-là. Go ahead.
So you'll find it here 7 statements only for the stroke. They are not measuring everything because this is a permanent standard of care they have. They have one for early assessment, time critical therapy, stroke unit care, early rehabilitation, and etc. For example, in front of every statement, they are putting indicator to measure in front of it. For the early assessment, you will find here, you can see here, indicator 1A, proportion of patients with suspected acute stroke who are assessed by ambulance service using validated stroke screening tool, and etc. So for every statement or for every standard, they will have one or more indicators to measure or to make sure that we have done what we are supposed to do.
Donc pour chaque élément, donc pour chaque standard, en fait, il y a un indicateur qui est mis en place pour s'assurer que l'on fait ce qui est censé faire et qu'on a le résultat qui est escompté. Donc, par exemple, le premier point, donc, on nous a donné un exemple en montant. Vous pouvez voir, en fait, c'est les références, le point 1 avec le point 1, le point 2 avec le point 2. Donc, pour chaque élément, il y a un indicateur pour pouvoir mesurer ce qui est mis en place pour savoir si on a bien fait ce qu'il fallait. Go ahead.
And you can find here, for one statement here, one indicator to measure. But for example, for statement number 2, time critical therapy, you will find 1, 2, 3, 4 indicator to measure. So it's according to the need. Some statement will find one indicator, some will find more than one indicator.
Donc, et les indicateurs, en fait, peuvent varier, cela dépend du besoin. Donc, par exemple, si on voit pour les éléments qui nous ont donnés, donc par exemple l'évaluation, pour l'évaluation initiale, donc là, on n'a qu'un seul indicateur. Par contre, sur les thérapies qui sont sensibles au temps, à ce moment-là, là, on a 4 indicateurs. Donc, c'est vraiment relatif à ce que l'on attend et c'est le besoin que l'on a. Go ahead.
Okay, I'll stop share this one if you get the idea of the clinical care standard and how to develop it. And I'm going to show you another example of different system of clinical audits. Also, I shared in building it. It is of Saudi Arabia Clinical Audit Program.
Okay. Donc là, il va nous partager ce qui est fait en Arabie Saoudite, donc l'audit clinique qui est fait en Arabie Saoudite pour donner un exemple.
Can you see it?
Yes, we can. Yes, we are.
Okay.
Yes, we can.
Okay. In this program, it's not going by diseases, it's going by services. So you'll find here it is divided by to clinically auditing the maternity care, the venous thrombosis care, the critical care, nursing care, emergency care, and inpatient care. It's divided by this way.
Donc là, on n'est pas sur une division, par exemple en Arabie Saoudite, on n'est pas sur une division par maladie, mais par service. Could you go back for the different services? Oh, okay, I have it here. Donc par exemple, on a les services d'urgence, les services de maternité, d'infirmerie. Donc c'est vraiment en fait des indicateurs qui sont faits par service et non pas par maladie. Donc comme vous pouvez le voir, comme il a expliqué depuis le départ, c'est par rapport aux besoins dont on a des différentes instances.
For example, let me here focus on the emergency care. You find 3 indicators. The first indicator, proportion of patients who accessed the acute care of myocardial infarction within the specific time of care. Let us see how we can have it like indicator. That's it. We'll have the time from door to echocardiogram, the door to needle if we're gonna do PCI, from the door to ballon, before PCI, or door to ballon, and exclusion and formula. I will not go through the details, but I want you to imagine with me how the system is being developed.
Donc là, il ne va pas aller sur les détails exactement, mais par exemple, là, vous pouvez voir que okay, thanks. Vous pouvez voir qu'il y a que pour chaque indicateur, donc là, par exemple, c'est la proportion de patients qui ont eu accès aux soins, et pour chaque point, on met vraiment des détails sur des KPI en fait, qui soient spécifiques. Donc, on va autant aux détails nécessaires que possible. Go ahead.
I'm sure, Shiraz, I made your life like hell.
You keep on going. It's okay.
This is the last.
So one
document.
one second, Dr. Safwat. They're telling me that the sound is not good. So is it for Dr. Safwat or is it for me? Can you just let us know all if you can hear Dr. Safwat? Si vous pouvez m'entendre également, si le son est bon, just let us know. I just want to make sure that we can hear everyone and everyone can hear.
My voice or Dr. Safwat?
I don't know. Well, I hope it's okay. Dr. Hamed, you can. Let me try to hear something. Well, I think it's. Well, it seems to be okay now. So go ahead.
Okay, this is the last one, and this is the data collection form regarding COVID-19 clinical audit. And this is very detailed one. And let me tell you a little bit about how to develop this one. First, we need to have standards to build on, as we agreed before. And here we have built it according to the national standard of the country this was built in.
Donc, comme vous pouvez le voir là, donc vous avez parlé tout à l'heure des formulaires de collecte de données. Donc là, c'est un des exemples pour vous montrer en détail comment cela doit être complété par le patient pour la coronavirus. Go ahead.
Okay, you'll find here, it is like that. It's very detailed form, as I'm telling you. That's why it is the one of temporary audit. It's not done all the time. It's only in the period of pandemics of COVID-19, because it's very detailed and it's not done for all patients.
Donc là, comme vous pouvez le voir, c'est très détaillé parce que quand on va sur quelque chose de temporaire, on a tendance à aller sur quelque chose de beaucoup plus détaillé. Donc c'est pour ça que là, on est sur quelque chose pour la Covid-19, donc on essaie d'avoir les données les plus importantes.
You will find. Okay.
Go ahead.
You'll find here patient code number, hospital code number, patient age. This is the general data for the statistics. Patient weight, length of stay in the hospital, in the regular ward, in the critical ward, and total stay for both. Then the patient following having any risk conditions or not, and we need to tick yes, yes, yes if he has any risk condition. Then we'll go to when the patient was admitted to the hospital. He was admitted at which stage, and we are describing each stage: stage A, stage B, stage C, and then during admission, he passed through which stages, again, stage A or stage B or stage C. And then the third part about investigation done for him, and treatment done for him, hydroxychloroquine, chloroquine, or QTC for ECG, everything you can imagine. And this is called, or this is considered detailed clinical auditing. And about the complication, if the patient developed complications or not. I did this one with two systems. One of them is very well developed system who already transformed or converted this one totally to be automated system. So it is very easy to be done on mobile app or on the computer. And even they are dealing, using it for treatment of patient as bundle of care. Other systems are using it manually, paper-based, and that's why they are doing it for only sample of patients. Shiraz.
Sorry, thanks. I was muting myself. Donc là, comme vous pouvez le voir, il a donné tous les détails pour le formulaire. Donc il y a les nombres de cas, le protocole de traitement qui a été choisi. Can you go down a little bit for the form so that I can give some extra data, the one that you have given besides the treatment?
Thank you. I wanted to thank you. Sorry for taking too much time, but I wanted to explain to you that really don't take it as guaranteed that if you are giving the people standards to follow, that they are already following. You need to have a tool to make sure that the right care is being provided. Thank you.
Thank you so much. Merci beaucoup. Donc, docteur Sapois disait, donc il faut bien comprendre que pour tout ce qui est audit clinique, on ne peut pas prendre ça à la légère et que c'est vraiment important que ce soit mis en place régulièrement et que l'on fasse cet audit à chaque fois. Thank you so much, Dr. Safwat. Thank you so much for all the participants. We're going to move forward to the presentation of Dr. Benjamin Judalbay. So just actually because we have been joined by some other people, so I just want for everyone to be aware that we have Dr. John Oladiju from the Nigeria CDC with us. We have Dr. Franz Simon from the Ministry of Health of Ivory Coast. Sorry, we have Dr. Zuberi Muvini from the Ministry of Health of Rwanda, and Dr. Benjamin Judalbay from the Africa CDC. So, Dr. Judalbay, the floor is yours.
Thank you so much. Thank you, Shiraz, for inviting me. And sorry for this internet challenge that I had. I was unable to connect to internet home, and I have to rush to the office to be connected here. So sorry for that.
Thank you so much.
Yes. Can we have my slides from?
Yes. 1 second. I'm pulling that out.
The presentation will take maximum 10 minutes. It's not a long one, very short. Since I have another commitment at 3, so that let's do it quickly. So let's have the slide and move on. My presentation will be in French, but I have my slide in English.
Yes. Well, you can do, but I'll make sure, because I know that we have most of our speakers that do speak English.
Is everybody okay with English or French? Whatever language, I am okay.
I think you can do it in English. I will do the main translation at the end, because I know we have a journalist from Algeria who speaks mostly French. So that's why, but you can do it, I think, because most of the attendees and the panelists now are English speakers. So okay. I think it's better we do it in English. Sorry, I was
it's okay.
Opening at the same time the presentation.
So open the English slide.
Yeah. It's being open, my computer. So yeah, so today Dr. Judalbay will tell us, so we're talking about strategies of deconfinement. And please, if on entend, Dr. Hamadi, est-ce que vous nous entendez? Parce que Dr. Hamadi me dit on n'entend rien. So while the slides are opening up, I just want to make sure. Dr. Hamadi, just if you can raise your hand, si vous pouvez juste lever la main si vous nous entendez, juste pour m'assurer. If you can just raise your hand if you can hear us, or if, so that I'm just aware of that. Okay. It's opening up. Sorry, my computer is a bit slow. Should have opened it before. Also, if you have any questions, Monsieur Mendes, si vous avez des questions, you can start like putting them in the chat so we can take them afterwards. And then after we will continue anyway with the debate. Okay. Why aren't you taking so much time to open? Should have opened it before. Why is it take? Oh, here we go. Good. I was starting to get. So I'm just gonna. I'm just gonna share my screen. What is it? So it's opening up. So it says that I had to make sure that it was a trusted source. So here we go. I don't see it. Here we go. Can you see the presentation?
Not yet.
Okay. Because it says that it's shared the screen. So. Because it is shared, so just let me know.
See now, can you put on slides mode?
Yeah.
Yes.
Okay, let's do it. Everyone can see it?
I can see it.
Okay, so I think if you can, everyone should be able to see it. So
yes.
We can continue.
Thank you so much again, and my apologies for this technical challenge that I had. I'm going to take you through on the easing the COVID-19 lockdown. We know that one of the effective measures that was put in place by different member states or different countries across the world was the implementation of the lockdown. And there were different type of lockdowns across countries. So can we have the next slide? So these different measures included the personal protective measures like hand hygiene, respiratory etiquette, environmental measures, physical distancing measures, with isolation of cases and quarantine of contacts, individual physical distancing, school closures, movement restrictions with the lockdown of communities, travel-related measures with border closures and travel bans. So all these measures are the lockdown measures that were put in place by different countries in order to control the spread of COVID-19. Next slide. So, now I'm going into the details of the public health and social measures that were put in place. What was the purpose? The countries went into lockdown because they need to slow the transmission, and I'm speaking on the African context. And they also protect medically vulnerable and other high-risk populations because we know that people with hypertension, diabetes, and other comorbidities are very susceptible to get COVID-19 infections. And also, this help countries to buy time for scale up the response effort and development of treatment and vaccines, even if we are far from an effective treatment and vaccine. We know that many clinical trials are ongoing currently. And we know also that these measures can be harmful to economies and livelihoods, medical services, In some countries, for instance, they locked down all the hospitals. So it was even very difficult for a woman that wanted to deliver to get access to services. And this one also exacerbated already existing inequalities. Next. So this is just a map of member states that are imposing travel restrictions as of 24th May 2020. And the situation is evolving now. Some of them are lifting these restrictions, but as of 24th May, 43 countries have full border closures. 7 with the international air traffic closures, except for cargoes, and 2 have travel restrictions to and from specific countries, and 2 has entry and exit restrictions. So if you look at the different colors here, you can see which country is implementing what measure. Next slide. Yes, this is just a summary of the mitigation measures implemented by member states. It goes from the closure of educational institutions to the national lockdown. So when inside the circles, it's just the number of the countries that are implementing the measures. Like, for instance, if you take at the mass screening and testing, 18 countries are enforcing that one. And as of 26 May, some of the countries started easing the lockdown, and in order to allow movement outside the homes, for the businesses to allow business to open, and also they open these religious institutions, allowing people limited gathering of people. Next slide. So, what about Africa? We can say that the lockdowns in Africa was early, and the public health and social measures initiated by different countries in Africa slowed the transmission, and we can see today we can say that we have not yet reached the peak of the coronavirus in Africa compared to the other continents, or compared to the other countries across the world. And this has caused significant social and economic disruption, according to the World Bank and the Economic Commission for Africa. 65.7 billion per month of lockdown that is what is causing to Africa economy. So it is very, very huge, and it is about 2.5% of the annual GDP of this continent. So it is very, very, very huge. That is one of the reasons why we at the Africa Centers for Disease Control and the African Union, we have developed the guidance on easing the lockdown. How do we ease the lockdown? We know that many countries are now moving to easing the lockdown. Next slide. What do we do? Prior to easing the lockdown, we need to conduct a risk assessment to understand the impact of the lockdown in these countries. We need also to ensure that key systems are in place in terms of surveillance, in terms of testing, in terms of medical services, in terms of community engagement. Whatever we are doing, if we don't get community involved, it will be extremely difficult. And even going to the lockdown, community should have been advised on the rationale behind the lockdown. And we need also to meet the criteria for easing the lockdown. And there are some set of questions, and there are essentially 3 questions that we need to ask ourselves. Is the epidemic under control? How is the reproductive rate of the infection? Is it the infection growing or regressing? That is something that we need to ask ourselves. Is the health system able to cope with the resurgence of COVID-19 that may arise after easing the lockdown? We have seen on TV that some part of Germany is going back to lockdown. And that is a big lesson for all of the countries that are moving to easing the lockdown. And the third question that we need to ask ourselves is the public health surveillance system able to detect and manage the cases and their contacts and identify a resurgence of cases? So these are the three major questions that we need to ask ourselves before easing the lockdown. Do we meet these criteria? Next. So when we move to easing the lockdown, we need to go stepwise. And the first step is to implement it at the smallest geographical unit possible. You don't go to, when you go to national lockdown, don't go to national easing of the lockdown. We need to ask the set of the questions that in the previous slide, and you move from the smallest geographical unit to see, even in a town, for instance, which area is most affected and which area is relatively safe, where you can ease the lockdown. So you can ease the lockdown step by step. You can also determine which measures should be eased. We need to ease the most detrimental measure to the communities first. For instance, health services, if they are closed, so marketplaces, but in a very limited area. Okay, is also the public health and social measures gradually and monitor the outcome. And we need to go back to the criteria that I mentioned in the previous slide. Is the epidemic controlled? Can the health system cope? Is the surveillance system able to detect the new cases and trace all the contacts? And it is like you have a mountain. When you want to go to the top, you have to go step by step. You go somewhere, you stop, you rest, and then you move, so and so. And you need to wait 2 to 4 weeks between the lifting the measures to determine the effect. But for sure, easing the measures will inevitably result in increase of transmission of new cases. And the key word is to be ready. And we are seeing with Germany, we have seen also in China, the resurgence of cases. So it is a lesson for all of us to learn. Next. So there are 3 steps when you want to open. The first step is to open essential shops, border for essential travel of workers and goods, allowing social gathering, but for less than 10 people with physical distancing, and maintain non-COVID essential health services is very important. Immunizations, maternal health services, and other HIV, malaria, whatever. The primary health care. We need to look at this kind of essential services. The step 2 is to open non-essential priority businesses, large markets for essential goods, border for trades and travel with point of entry controls. I have seen also on TV that countries that are easing now the lockdown are reinforcing the surveillance at the point of entries in the countries by putting, for instance, thermal scanners at the airport, checking the temperatures, assessing individually the passengers that are getting in the countries. These are the measures that we need to have in place. Opening the schools, especially for priority years, for those who are in the Francophone system, those who are going to have what we call the baccalaureate, for instance, which is the first degree, allowing them to go to universities. This is very critical. You need to open these years, and the selected venues like churches, mosques, restaurants, and expanding to non-COVID health services, and including the routine immunization. And the step 3, when the situation is okay, now you can open all the sectors, but we need to provide social distancing and hygiene, hand hygiene, should be maintained. That should be maintained. We should not go back to business as usual, but this COVID is a huge lesson for us to implement the infection prevention and control measures. Next. This virus is here to stay. We don't know how long. People are saying that no, we will see it in seasonal. But for now, nobody has the answer. And we need to have a long-term behavior change. And for the member states, they need to provide risk communication and community engagement on non-contact greetings. This is something that should continue. Hand and respiratory hygiene and etiquette, we need to continue, maintain at least 1 meter distancing. It's very important. If we want to go back to our normal life, we need to change the behavior. We need to provide to community members by maintaining the provision of hygiene materials. That is very important. And this should be budgeted by different countries and take into account in the routine service delivery today. And also make improvements to watch infrastructures. Very, very, very important. If you don't have access to water, hygiene and sanitation, it will be very difficult. So this is a call for different countries also to make investment in that one. Let me give you an example. For instance, when cholera occurs somewhere, the consequences, the Ministry of Health will deal with the consequences, but the Ministries of Health are not the one putting these infrastructures. This has to deal with, I don't know, public or whatever we call it somewhere else. So, but they are not seeing that these guys are not doing their job. But the Ministries of Health who are dealing with managing the consequences of lack of investment in this area, the Minister of Health, if the death increase, he will be the one to be kicked out of SAC, but not the Minister of Infrastructure, for instance. So this is something that we need to understand very well. Next. We are almost done. So we need to have some specific consideration for Africa. And in Africa, we have informal settlement. 57% of the urban population live in densely populated informal settlement or slums. And how do you implement these measures in this kind of settings? Extremely. So this is a consideration for Africa. Africa needs to be innovative, thinking, finding the way of dealing with this challenge. We have also the age distribution, which seems to help a little bit with the coronavirus in Africa, that we have a younger population, and the different comorbidities and other infectious diseases. We know through the literature, the other comorbidities such as diabetes and other comorbidities, non-communicable disease comorbidities, but we don't know much about HIV, TB, and malaria, including even malnutrition, stunting, and all those kind of things in Africa, which is our big problem. So we need to look at, and this is a call for colleagues, clinicians, to look at closely why people who are dying or people who are getting infected by coronavirus, what are the comorbidities in the African context. So it is very important to look at those, to look at this. Next. So I just to thank you, and thank you again for this opportunity. Let's keep watch our hands. Thank you.
Thank you. Well, thank you so much, Dr. Judelba. Donc, je vais juste faire, I'm just going to translate very briefly the main points, and please don't hesitate to add on if I'm forgetting something. Je vais juste vraiment traduire rapidement les points les plus importants donc, de la présentation du Dr. Judelba. Donc, c'était vraiment d'abord commencer par expliquer les différentes mesures qui avaient été mises en place par les pays, que ce soit donc la protection personnelle, la mise en place des masques, la communication pour se laver les mains, la distanciation. Après la question des infrastructures qui étaient fermées. Après, le point important quand on va regarder l'aspect de déconfinement, c'est s'assurer que la maladie est sous contrôle. Petit 2, voir si le système de santé pourrait gérer la résurgence du virus, comme on peut le voir ce qui se passe en Allemagne et en Chine, et aussi de maintenir une surveillance et une veille sanitaire de ce qui se passe pour la coronavirus. Donc, il expliquait que quand on va regarder pour faire un déconfinement, déjà petit 1, il faudra, pour chaque mesure qui est mise en place, avoir entre 2 et 4 semaines pour s'assurer que les mesures sont efficaces et voir quels sont leurs effets, et aussi de le faire graduellement, commencer avec les éléments les plus, avec les infrastructures et les business essentiels, après aller en deuxième étape, aller sur des business non essentiels, l'ouverture des frontières et aller pour les services de santé qui sont non liés à la coronavirus. Et l'étape 3, de tout ouvrir avec un retour entre guillemets à la normale qui ne sera jamais normal, mais qu'il faut toujours s'assurer et se rappeler que la coronavirus fait partie maintenant de nos sociétés, qu'on doit toujours garder cela en tête et qu'il faut s'assurer de toujours avoir une distanciation sociale, mais aussi toujours se laver les mains. Et l'autre point qui était important, c'était l'importance de laver les infrastructures, d'être toujours avec une hygiène impeccable. Et le challenge que l'on a aussi spécifiquement en Afrique, c'est la question de l'âge de la population. Donc ça, c'est à prendre en compte. La deuxième chose, c'est les effets de comorbidité avec les maladies telles que le VIH, la tuberculose, la malaria, et aussi le fait qu'en Afrique, dans beaucoup de pays, beaucoup de personnes vivent dans des bidonvilles ou dans des endroits à forte concentration humaine. Donc c'est quelque chose qu'on doit vraiment prendre en compte quand on va sur un déconfinement. So this was just to translate briefly the presentation. Thank you so much, Dr. Judelbay. So what I would like to do now is to open up the floor for some questions and a real debate. Donc là, je voudrais vraiment ouvrir la parole pour les questions et le débat. Et what will be important, I would say, is also to see how we can, as we are different countries represented here as well, how we can cooperate together to make it an easy process also when it comes to deconfinement, but also towards this fight against COVID-19. Donc vraiment essayer de voir déjà pour commencer sur la question comment augmenter cette coopération africaine, assurer que cette transition vers un déconfinement sur le continent se fasse de la manière la plus facile et que la lutte aussi contre la coronavirus soit un peu plus, je dirais, plus collective. So I'm opening up the floor for the debate. So if somebody wants to jump on and have the first comment, go ahead. Dr. Dubada, Dr. Hamadi, Dr. Beyeni, Dr. Oladijo. The floor is yours now. Et si vous avez des questions, if you have any questions, don't hesitate to put it also in the chat box if you're not part of the panelists. Dr. Hamadi, est-ce que vous nous entendez? Est-ce que vous êtes là avec nous? I know we had some internet problem with some people today, unlike its last session. Dr. Beyene?
Yes, cheers. How are you?
Okay.
I'm here.
So would you like to follow up on the question, open up maybe like the debate and see how do you see also the forthcoming when it comes to COVID-19 and potentially also the African cooperation, but having in mind this idea of deconfinement?
Well, like I said, in Ethiopia, we have not had a confinement initially. So rather we're walking slowly into more of a strict social distancing and strict measures on emergency and on the state of emergency. So for us, it is too early to talk about deconfinement because we didn't have a lockdown initially. And also right now our cases are on the rise.
Okay, so what are, Dr. Oladejo, you wanted to say something?
Yes, for Nigeria, we had a lockdown Initially for the first 2 weeks, then later on it was extended for another 2 weeks. Then thereafter, we now start easing the lockdown. But as the case may be, the cases are still going up. And so we just have to ease the lockdown. We can't continue to keep people in the home. You know, the only thing was that there was a palliative that was given to the community by government, but that palliative is not enough to go around everybody, especially the those destitute and those vulnerable people. So what we did was to really ease the lockdown in the first 3 weeks, and then we're trying to now open some industries. You know, we have not actually opened to the churches and mosque for now, and maybe by next week, government is going to announce the opening of the airport. So these are the measures we have actually taken, and then we continue to work on that. But as the case may be, we're not going to the community to actually do what we call community engagement, because people do not believe there's still COVID-19 in the country. So we needed to do a lot of risk communication. We needed to do a lot of engaging the community leaders, the religious leaders, the traditional leaders, so that they will be able to take all the non-pharmaceutical interventions like washing of hands, use of a face mask, and social distancing. So these are the things we are doing. Thank you.
Thank you. Donc, Dr Oladejo, il nous expliquait qu'au Nigeria, donc, ils étaient en lockdown depuis 2 semaines au moins, et que donc ils sont en train de le faire graduellement, et que là l'idée c'est aussi d'impliquer les communautés, parce que beaucoup d'entre eux pensent encore que la Covid-19 n'existe pas. Donc c'est l'idée de vraiment informer, de communiquer avec eux. This is actually a very interesting point that you were mentioning, Dr. Oladejo, that I would like to extend to Dr. Dudalvai, Dr. Beyeni, Dr. Hamedi, Dr. Mughuli, and Dr. Blahiri, is that how, as we talked about it last week, that communication is key in the fight against COVID-19. How do you deal with engaging with the community and making sure that they do understand that this disease is an actual reality, and they understand that this is not like a made-up disease, as we might see in some countries, that people do not believe in the existence, and that also when we are easing up the lockdown, that people think that we are actually back to normal? How can we make sure that in Africa people still understand that this disease does exist, is here to stay, and that even if we are easing the different measures, we have to make sure that we are still very acute and very conscious and aware of this. La question que je pose par rapport à la COVID-19, c'est vraiment cette question de communauté, de s'assurer que la communauté comprenne bien l'existence de cette maladie, que ce n'est pas une maladie qui a été inventée, et malgré le fait que l'on va aller vers du déconfinement et un retour entre guillemets à la normale, s'assurer que l'on reste quand même très conscient de la situation actuelle. Donc comment est-ce que l'on peut faire face à cela? Dr. Dudalvai, would you like to add something on this point? Dr. Beyeni, anyone wants to, you can just unmute yourself.
Yeah.
And yeah, Dr. So who wants it? Okay, Dr.
Yes.
Oladejo, go ahead.
Okay, we realize that the right messages are the key to this. We need to actually develop the right message and then deliver it to the targeted audience. So we have a communication crisis management team that look into this and then develop messages which are actually delivered at the grassroots level. So what we did was that we have what we call National Primary Healthcare Development Agency, and this agents, they have all their staff at every local level. at every community, more than 10,000 of them. So we made use of this agency to really train their staff on how to engage each of the community where they reside. So they listen to them because this staff, this health worker, they work in those communities. So they listen to them. They come to them when they have malaria, when they have any illnesses, they go to them for treatment. So we are using this set of people to be able to reach all the people at the grassroots level, to be able to explain to them that this COVID-19 is real, and that if anybody has it, it doesn't mean that it is a death sentence. Something that can be, although we don't have vaccines now, and we don't have a special treatment for it, but if you report to the nearest health center in time, you will be treated and then you will be all right. So these are the messages we are doing, and then we key into the traditional system, because people listened to their opinion leaders, to their traditional leaders, as well as to their religious leaders. So we are actually engaging these people to be able to reach their subjects at that particular level. So these are more are what we are doing to ensure that the key messages reach the target. Thank you.
I'm just going to translate quickly this, and Dr. Beyeni, then I'm going to give you the floor. Donc, comme expliqué Dr. Oladejo, ce qu'ils font au Nigeria, c'est exactement ça. Ils ont compris l'importance d'inclure les communautés, mais aussi de travailler avec des leaders religieux ou des leaders d'opinion des pays pour vraiment transmettre ce message, pour s'assurer que la population est engagée et sensibilisée et vraiment en fait prenne au sérieux cette maladie. Dr. Beyeni?
Thank you, Shiraz. So what we did is just like what my colleague just said, we have also an emergency risk communication team under the Emergency Operations Center. And what they basically do is they try to develop message from communications perspective in all other pillars, from the case management, from the supply chain, from the surveillance, and from the resource mobilization, everything. They actually gather messages and develop them into the communication material. What they differently did, I believe, is they have engaged community leaders, faith-based leaders, and also actors who are famous in Ethiopia right now to communicate the message regarding the COVID transmission, how to prevent it, what does it mean when you have COVID and everything. They have also engaged with people who had corona and treated in one of the treatment centers, and they asked them to speak up about what their experience looked like while they were being treated. How did they think they got it in the first place? What were their biggest fear and what were their biggest challenge during their treatment and everything. So that actually has been helping the people understand and comprehend what the disease is and what it looks like once you have it. And we have this in different major languages in Ethiopia so that we get closer to the people so that they understand. The other thing that we're trying to communicate at the same time through the same platform is that what does it mean when you don't have a lockdown and how to social distance? Why aren't we having a lockdown that everybody that talks about? How to distance yourself from the crowd, how to distance yourself, how to home quarantine. Now we have started home isolation as well. So how do you do that? We do communicate it through, we use our actors and community phase leaders as well. So these are the things in perspective of the communication. Regarding the press releases on how the cases are going up, how many days do we have, how was the diagnosis, how many laboratories that we did, that is directly communicated by Her Excellency Dr. Leah, our health minister, so that people actually feels closer to the situation and everything. We also have doctors in treatment centers and doctors in non-treatment centers to speak about COVID-19 so that people will be able to see the different perspectives of the management and the situation in Ethiopia. We have a scientific advisory council. We also bring them on board and press releases at times, so that people feel like it's not only the government officials giving press releases and everything, but also the scientific committee as well, so that they know that this is a fact, not a propaganda or something else. So that's how we're doing it.
Perfect, thanks. I'm just going to quickly translate. And I'll give the talk to Dr. Hamadi. Donc, Dr. Beyeni explique qu'en Éthiopie, de même, ils font appel aux leaders de communauté, aux leaders religieux, afin de les avoir impliqués. Et aussi, très important, ils font parler les patients qui ont eu la Covid-19 pour qu'ils puissent partager leur expérience sur les traitements qu'ils ont eus, sur la maladie en elle-même, pour que les gens prennent conscience. Et puis également, donc c'est fait aussi sur les différentes langues en Éthiopie pour que ça puisse atteindre le maximum de personnes. Et aussi, leur ministre, Dr. Lia TDC, partage régulièrement le nombre de cas, ce qui se passe à travers des communiqués de presse pour qu'ils comprennent que ce n'est pas une propagande, mais en fait une réelle réalité. Dr. Hamadi, est-ce que vous êtes toujours avec nous? Normalement, oui. Je m'assure si vous pouvez mettre unmute pour partager un peu l'aspect de l'Algérie. Alors, Dr. Blehiri, I don't know if you can unmute yourself. Dr. Judalbay, est-ce que vous avez un commentaire par rapport à ces aspects-là sur comment s'assurer que les communautés comprennent que ce n'est pas, on va dire, une maladie fictive, mais une réelle réalité de société? So I'm just asking Dr. Judalbay about his point of view on this aspect.
Merci beaucoup, Shiraz. Je veux faire ma dernière intervention et je serai obligé de
parler.
Oui.
Docteur Judalbay, est-ce que vous avez un commentaire par rapport à ces aspects? Je m'entends en écho.
Est-ce que vous m'entendez?
Par contre, je m'entends en écho et Docteur Judalbay devait... Que ce n'est pas, on va dire, une maladie, un petit décalage. Réalité. Je vous mets sur muet vite fait pour que Docteur Judalbay puisse intervenir. Et puis après, je vous reprends. Par contre, je ne sais pas pourquoi on a un double... Allez-y, Docteur Judalbay.
Oui, non, merci beaucoup, Shiraz. Je disais que je vais faire mon dernier commentaire et je serai obligé de partir parce que j'ai une réunion qui commence dans 3 minutes là. Et il va falloir que je parte.
Bien sûr.
La question des communautés doit être centrale. Hein. La communauté doit être centrale dans tout ce que nous faisons. Moi, je pense même que ça doit aller même plus loin depuis la définition des politiques parce que généralement, les communautés se sentent imposer des choses. Et ce n'est pas la meilleure façon de faire. Quand on impose des choses aux communautés, il faudrait que les communautés se sentent engagées dès le départ de la définition de ces politiques jusqu'à leur mise en œuvre. Et maintenant, quand nous gérons une situation aussi grave que celle que nous avons entre les mains, cette pandémie de coronavirus, mais la maladie, c'est d'abord dans les communautés. C'est là-bas qu'il faudrait aller. Il faudrait avoir leur adhésion. Tant qu'on n'a pas leur adhésion, toute politique qui sera, ou bien toute intervention qu'on voudra mettre en œuvre dans ces communautés, mais les communautés vont penser que nous les faisons contre elles et sans elles. Donc, elles ne seront pas partie prenante. Donc, c'est en fait une attitude de négociation permanente avec elles pour pouvoir avoir leur adhésion. Et il ne faudrait pas aussi penser que, par exemple, dans le cadre de la santé publique, les connaissances ne viennent que des experts. Il y a beaucoup de connaissances qui sont également au niveau des communautés et il faudrait se mettre à l'esprit qu'on peut apprendre beaucoup de choses de ces communautés-là. Ces communautés ont toujours été résilientes et bien avant même des questions de santé publique moderne. Hein, et ces gens-là ont eu à gérer beaucoup de cas de maladies, d'épidémies sans intervention extérieure. Ça s'est passé plusieurs fois. Il faudrait remonter un peu l'histoire pour comprendre comment les gens ont toujours survécu jusqu'à aujourd'hui. Donc, c'est un réservoir de connaissances, c'est un réservoir de savoir qu'il ne faudrait surtout pas négliger. Merci.
Okay, merci. So Dr. Judalbay was explaining how, yes, communication has to be central and a center of whatever we're doing when it comes to healthcare to make sure that we have people adhering, but also what is important is that we don't only hear from experts, but also from communities, from people who have like the experience when it comes to the management of these diseases, who have survived. And it's not only about COVID-19, because this can be extended to any disease. So this is important that we continue the communication and exchange of good practices. I want to jump into this. Et Dr. Toubalwa, je vais vous poser une dernière question avant que vous partiez. Et Dr. Hamadi, je vous prends la parole juste après. Parce que Dudalbaï doit partir. Par contre, juste si vous nous avez live en même temps sur YouTube ou autre, me coupez parce que je m'entends sinon en écho. Mais Dr. Dudalbaï, je voulais voir. I had like a quick question that is something that I want to ask everyone at the same time. I have launched this little poll in the Zoom because I think it's important that we continue this discussion, and we could see the need for this African integration. So here's a question for you quickly, Dr. Judalbaï and Dr. Hamadi would like to tell you something, so I might take 4 minutes from your time. How would you see an implication, and how would you think of involving more communities and more ministries of health from Africa, and really having the communities, the experts, and the ministries to discuss further, to have such platforms, and to continue to make sure that we improve the healthcare system, and we make sure that we have everyone adhering to what is done. So it's not just from, for example, only Africa CDC to the population, only ministries of health giving, but also getting the information back from the communities.
I will give you a practical example that in my previous life, I was one of the key actors. There was a project for water and sanitation in a village. And my answer I will give you that answer, and you will understand why I don't want to go to elaborate further. I will just give you the example, and it is a very big lesson for all of us. So, you know, there was this, people went to that village to see that, no, there is a lot of, they have many challenges of, you know, waterborne diseases in that area. And when the team, the investigation team went to understand what has happened, they noticed that the wheel is something at 5 kilometers from the village, 5 kilometers away from the village. So they went and report back that no, when in the process of going and getting this water, and ladies, women walking 5 kilometers back to the village, is explaining why the water is contaminated and all those kind of things. So they decided to drill a well in the village. So they came. They drill a well somewhere in the village, and they came. The situation has not improved. The district medical officer is reporting the same numbers of waterborne diseases. So they decided now to send a team of sociologists, anthropologists, and all these experts. Now they went in a team to understand what is happening. When they went, they decided to do a focus group for women, for young people, for elders in the village. And when they did that one, the women said, no, you know, for us, the only time we have for ourselves is to walk. And during our walking is when we, as women, we are discussing our challenges. We are resolving our problems. You know, that is the only time we have for us. Now, when they went to the elders, they said, okay, why nobody is using the wheel that was just drilled in that? They said, how do you want us to use that one? This is the entry to the holy wood. This is the entry to the holy wood. How do you want us to go? Nobody is going to use that one, because this is where the ancestors are located. They are doing their things. When they are doing their sacrifices, they go to that area. And the young people say, no, we have been always prevented by the elders to move to that direction. So you will never ever see a young person to go to that. So, you know, that is and it came very late. they should have started from there to come and understand why the wheel is 5 kilometers away from the village. Women, what are young people? What are your problems? Elders, what are your problems? And then we speak the same language with the community before we implement anything. I will stop there. Thank you.
Okay, thank you so much. Dr. Judelbaï nous donnait un exemple pour expliquer que quand on veut impliquer les communautés, il faut déjà comprendre en fait les réalités des communautés, les règles au final dans lesquelles elles évoluent avant de pouvoir en fait proposer des solutions. Alors juste avant que vous ne partiez, Dr. Judelbaï, je vais donner vite fait la parole à Dr. Hamadi pour qu'elle puisse interagir parce qu'elle voulait réagir sur quelque chose que vous avez dit. Comme ça, je vous laisse partir et on va continuer le débat. Dr. Hamadi, vous pouvez alors j'active votre micro. J'espère que je vais juste pas m'entendre en plus. Dr. Hamadi. Activer son micro. En fait, proposer des solutions. Alors, Dr. Hamadi, je m'entends en micro. Je ne sais pas si vous nous regardez en même temps sur Facebook ou sur YouTube. Juste couper cette page-là, qu'on puisse vous entendre, parce que sinon je...
Oui,
j'active votre micro.
Oui, c'est bon? Vous m'entendez?
Oui.
Est-ce que vous m'entendez? Vous m'entendez? Shiraz? Shiraz?
Oui, oui, je vous entends.
Oui, est-ce que vous m'entendez?
Je m'entends en micro. Je ne sais pas si vous nous regardez en même temps sur Facebook. Oui, je vous entends.
Mais parce que je n'arrivais pas. En fait, sur Facebook, parce que... Oui, vous m'entendez?
Oui.
Est-ce que vous m'entendez? Vous m'entendez? Shiraz? Shiraz?
Oui, oui, je vous entends.
Ok. Vous m'entendez?
Je vous entends.
Oui, oui, oui. Parce que je n'arrivais pas. En fait, sur Facebook, parce que... Oula. Oula, je suis sur Facebook parce que je n'arrive pas à me connecter sur Zoom. Ok. Il y a beaucoup.
Coupez le son de Facebook, juste vous coupez le son comme ça, on n'entend plus.
Oula, je suis sur Facebook parce que je n'arrive pas à me connecter sur Zoom.
Bon, docteur Judelbaï doit partir, docteur Hamadi.
Oui, je dois partir là. Merci beaucoup. On m'a appelé au téléphone. Là.
Il n'y a pas de souci. Allez-y, docteur Judelbaï. Merci beaucoup en tout cas. Le son de Facebook, juste vous coupez le son comme ça. Allez-y, désolé, j'ai dû couper parce que... Alors, docteur Hamadi, je vais vous donner la parole. Coupez juste Facebook parce que vous êtes sur Zoom avec nous. Donc, parce que sinon, on s'entend et, on n'arrive pas à avoir une conversation. So sorry, Dr. Judelbaï had to go for his meeting. So I want to continue briefly the debate for like 10-15 minutes, and then we will stop for today. But I'll wait for Dr. Hamadi just to stop Facebook so that we can hear. But what I would like to ask each of the participants is something to see, and I know Dr. Muni, you are in a meeting, so you can just write it down. But I wanted to see, should we decide to continue this initiative and to move into more maybe some actions, would you be keen, would you agree to be part of this initiative? Because as we had discussed last time,
je vais essayer de parler, j'espère que vous m'entendez.
Allez-y, allez-y, après je vous continue.
Shiraz?
On vous entend, Dr. Hamadi.
J'entends personne là, je ne sais pas si vous m'entendez.
Alors, je sais comment je vais faire. 2 secondes. Ici, tous les conférenciers. On vous entend.
OK. OK, merci. Merci, Shiraz. Je voulais juste partager l'expérience de l'Algérie parce que nous avons un réel problème d'adhésion de la communauté, parce que partons du principe que l'implication, c'est ce qui fait la réussite de la réponse, c'est l'implication de la communauté. Donc, nous avons, dès le départ, essayé d'impliquer tout le monde, donc via la communauté, via les affaires religieuses, via les écoles, même si c'est enfermé. Donc, il y a eu un concours des écoliers, des écoles privées et publiques et avec des diffusions, des scénettes, des petits spots pour sensibiliser davantage et pour parler des modes de transmission et des mesures barrières, de travailler avec les associations locales par rapport à ça en impliquant la population pour parler davantage des mesures barrières de la distanciation. Mais on se rend compte que malgré tout ça, c'est pas tout le monde qui adhère. Donc, on a un réel problème. Donc, il y a des personnes réellement qui sont conscientes, qui portent le masque, qui évitent de se sortir, sauf en cas de nécessité. Par ailleurs, on voit qu'il y a d'autres personnes qui ne croient pas réellement, qui ne croient pas, y compris parfois même personnel de santé. Donc, je veux dire que par rapport à ça, je ne sais pas quelle est la meilleure manière. Nous avons même testé une application, le CoCheck, pour une évaluation. Et je remercie Safouat par rapport à l'audit clinique. Et donc, audit pour tout. Je pense que même par rapport aux mesures, si on va on va parler des mesures barrières, des mesures d'hygiène à appliquer de la distanciation. Donc, nous avons essayé de faire une application, le CoCheck, pour essayer de voir est-ce que réellement ce que je connais, les mesures que je connais pour lesquelles j'ai été informée, où il y a les spots, il y a le site du ministère de la Santé, il y a tous les spots, tous les secteurs qui sont impliqués, qui font passer des spots à travers les télés, aussi bien publiques que privées, et radio aussi locales que nationales. Mais malgré ça, je veux dire, malgré cette évaluation, on voit que les gens n'adhèrent pas vraiment, et c'est ce qui entretient la chaîne de transmission. Donc, je voudrais bien demander à un autre collègue qui a bien parlé de l'implication des communautés, comment faire et est-ce que ça réussit ailleurs? Merci.
So Dr. Hamadi was explaining, and she would want to hear even more from you, Dr. Beyeni and Dr. Oladijo, is about how here in Algeria, we actually do have this problem. We have this problem of the population not adhering to what is done, even though they have tried to implicate the communities, that they communicate with it. They even did an app to really try to continue, but we see people who still today do not wear the mask, do not do the measures that do not apply the measures that are requested from the Ministry of Health. Don't wear the mask. We have some that do, but this is why in Algeria we keep on seeing this resurgence of COVID-19. So what would be your advice for, as you said, for example, Dr. Oladijo or Dr. Beyeni, that it did work for you, that it was successful? What would be your advice when it comes to that? How and what can be done? Because this is the problem that we are facing here in Algeria.
Thank you very much, Shiraz. As a matter of fact, we actually faced such initially, but what we are actually doing was to involve the community itself. So we have a program called Take Responsibility. The goal is to promote, the goal is just to ensure that we promote the right thing to do at the right time. I mean, to protect your health and to protect the health of your neighbor and your family. So we launched this particular program, and we actually ensure that it is owned by the community itself. So if I'm going out now and I don't wear face mask, you will see 1, 2, or 3 people that will actually, point it to me that, oh, Dr. Ladejo, you are not wearing your face mask. Where is your face mask? And you will see 1 or 2 people that will just bring out a new face mask from their bag and give it to you. So with this, people now realize that wearing a face mask is very, very key in whatever we are doing. And another thing is that for those people that are gathering together, they should not be, for example, there shouldn't be more than 20. And there should be a physical distancing of about 2 meters among themselves. So if we are coming closer to somebody, that person will say, no, please move a little bit back. There should be social distance. They themselves, they have already understood, and they are actually working towards it. So with this, everybody know that when you are going out or when you are in a gathering of no more than 20 to 25 people, you must wear your face mask and there must be physical distancing. So this is what we're doing.
I have a question for you before I do the translation at the same time. And Dr. Beyeni, that would be also a question for you. So I'm going to ask you the question. Is there any other ministries besides the Ministry of Health that is implicated for the confinement and for this communication with communities? Is there something, other measures that are put in place in addition to the communications that the ministries of health are doing in Nigeria, in Ethiopia, and all? I'm just going to translate quickly what you said, and then I'll let you answer that. Donc, docteur Oladejo expliquait qu'ils ont mis en place au Nigeria un programme qui s'appelle Take Responsibility, donc soyez responsables. Et il expliquait donc c'est vraiment fait la bonne chose au bon moment. Et c'est ça qui fonctionne. Et que quand vous avez par exemple, docteur Oladejo, une personne qui est vue sans masque, la population elle-même, en fait, leur dit pourquoi est-ce que vous ne portez pas de masque. Ils ont des masques en plus et le leur donnent. Donc, vraiment, la population est vraiment impliquée et c'est le cœur de la politique de communication. Donc, au départ, il y avait eu un problème, donc pas tout le monde adhérait, mais c'est quelque chose qui graduellement, on a vu une adhérence. Dr. Oladejo, would you like to answer the question I asked before I give the...
You interpret. So you were asking whether there's any other ministry that are actually supporting us?
Yes.
Is that the question? Okay.
Yeah, is there any other ministries of ministries in Nigeria that also play a central role in that?
Yes, we have Federal Ministry of Information that is actually assisting us. And this Federal Ministry of Information has an agency which is supervised called National Orientation Agency. National Orientation. So this agency has all their staff in every community.
Okay.
So in terms of IEC material, assist information communication materials, posters, they are the ones that are at the grassroots level that are actually disseminating this information. So our communication crisis management team have actually trained them from the national level to the state level and then to the community level. So they are the ones that are actually assisting and supporting each community on how to take responsibility for their health. So they go out in the morning, they meet with the traditional as well as the people that are working in the primary health care development agency to carry out these services.
Ok, perfect, thank you. So, Dr. Oladejo disait qu'au Nigeria, il y avait le ministère de la Communication qui travaillait avec eux, qui les soutenait énormément, surtout à travers une agence qu'ils ont, qui est impliquée et qui est introduite dans toutes les communautés au niveau du Nigeria, qui aide énormément dans la communication pour donc la Covid-19. Dr. Beyene.
Yes, thank you. So even in our setup, even with all the aggressive communication and everything, still there are challenges in adhering to all those recommendations. But I think what the very good thing that we've done is we have one national response, which is developed from multi-sectoral engagement. So our peace minister is engaged, our national disaster and risk management commission is engaged, all the transport minister is engaged, and everyone else is engaged, and they do their own also communication on their platforms. So it is a multi-level involvement. We engage volunteers. These volunteers they engage in the Ministry of Health communications team or any other team, with the peace minister, with the transport minister, with the NDRMC, and so we have a multidisciplinary approach for everything. The other thing is this all multi-sectoral response also involves the law enforcement. So, for example, when we started to implement the state of emergency, one of the things that was instated altogether was anyone cannot get out of their house unless they wear masks. So, and they also try to implement the physical distancing in marketplaces and in transportation areas were there to remind people to wear masks and to also physically distance from one another. So I think those two aspects has helped a lot, but still a lot is remaining in engaging the community to be responsible for their own health. So those are the things I see as good practices here. Thank you.
Perfect, thank you so much. Donc, Dr Beyene expliquait qu'en Éthiopie, quelque chose qui avait très bien fonctionné, c'était l'implication de tous les ministères, que ce soit le ministère des Transports, le ministère de la Paix, la Commission pour la réponse au désastre. Donc, vraiment, c'est ça qui a été clé. Et la deuxième, donc, tous ces ministères ont ça, on a donc le même message et on continue. Donc, okay, one thing that Dr Hamadi was saying that this is something, like you were saying, Dr. Oladejo and Dr. Beyene, that what you're actually talking, this is also something that is done in Algeria. I think she has a problem too. But the problem is they have put all this in place, but still with that, knowing that also the production and the distribution of the masks are done for free in Algeria, even with that, the population isn't that involved. So it's
I think what might help at this point is that involving the law enforcement. Yeah. Basically, our law enforcement helped in dispersing crowds and actually asking people to wear masks. In our country, we have not distributed masks, but the significant change has come when we implemented the reusable masks, which are actually most of them are locally made. Mm-hmm. We initially the communication was actually put anything on your face, like put any clothes to cover your mouth and nose, and put try to establish a widespread hand washing practices all over the place, and also teaching restaurants, pharmacies, and this shopping places, supermarkets, to mandate their customers to wash hands and to put masks on. Those are restricted measures that were taken, but also the law enforcement has significantly helped in making people put their masks. Nobody is allowed to actually board on any transportation unless they wear masks right now. So those are the things a little bit reinforced of people utilizing those recommendations.
Perfect. Donc, Dr Beyene disait que donc, un des points aussi importants, c'était l'implication des forces de l'ordre. Et c'est ça qui avait beaucoup aidé en Éthiopie. Donc, au début, d'ailleurs, la communication avait changé de mettez tout type pour vous couvrir le visage sans aucun problème à donc parce que en Éthiopie donc ce n'est pas gratuit. Maintenant ils ont introduit donc les masques réutilisables, mais c'est vraiment l'implication en fait des forces de l'ordre qui a vraiment changé la donne et on a vu une implication des communautés. Okay, perfect. Thanks. So I think it's very important, and I think this is a very important point that you mentioned, Dr. Beyene. That we sometimes we need to put like actually a law enforcement to make sure that people abide by the rules, because there is also, we are in a time when there is so much communication about this disease around the world that some people actually communicate give like fake information that some people might believe, and also because we do know that, as I think we see in anything, is that change and changing what has been the norm for such a long time, and the way we did things and we worked, and now we're asking people to change also in their way of living. This is also a bit hard for people to adjust to and adapt and understand it sometimes to some extent. So it is very much trying to make people aware that this is done for their sake and for their good, and not something that is done just because we want people to wear masks just for the sake of wearing masks. Here's a question that I would like to ask all the speakers, all the panelists, and Dr. Mugunya, as I mentioned before, I know you're in a meeting, but if you can type in, that'd be great, is moving forward. So today is the last session of the Africa Healthcare webinar series that we had intended to do. However, as we've mentioned, this is something that we believe should continue. And I'm happy to see that in the poll, actually, everyone said that we should continue to organize this on a regular basis. So, and that we are all in this way of trying to improve also healthcare systems in general, because also, although we're talking about COVID-19, it's about improving healthcare system and improving and increasing cooperation in Africa. My question is dual. First thing is, as right now we already have a couple of questions, a couple of countries represented: Algeria, Ethiopia, Nigeria, Rwanda, Ivory Coast. And as we said, we don't have to have the 54 African countries. If we want to start something, we can already start. First is, do you believe and do you think that as a country, and this is an initiative that you would like to see continue and that you could see yourself also involved in? And the second question is, how do you think we can even more learn from each other and cooperate on these healthcare questions? Because as we've had as an example right now on exchanging good practices, how we can continue doing this so that we can learn from each other, and really maybe for some, in some extent, the more we will have African countries represented, the more we can see cooperation also with countries that are in our border, to have like a very more united, a united front or a united answer to healthcare in general. So I want to keep it open to see what you think. I'll do the translation while I'll let the first person who wants to answer to that. Donc là, je posais la question de manière ouverte. On a pu voir avec le sondage que la majorité des personnes veulent qu'on continue en fait ces webinaires et cette initiative pour augmenter et continuer cette coopération africaine pour non seulement l'amélioration des systèmes de santé, mais aussi pour la lutte donc contre la Covid-19. Donc là, je posais la question déjà si on pouvait déjà compter sur la participation des pays qui sont déjà avec nous aujourd'hui, vu qu'on a déjà l'Algérie, on avait l'Égypte aussi, la Côte d'Ivoire, le Rwanda, l'Éthiopie, le Nigeria, et dans quelle mesure est-ce que l'on peut voir cette coopération prendre forme. So I open the floor to you for like the next 5-6 minutes to try to brainstorm on what we think, and we obviously will stay in contact to continue to see what do you think can be done and how can we do it. So if somebody wants to say something before we close up for today. Dr. Hamadi, Dr. Bayani, Dr. Bayani, go ahead.
Well, I think this should continue. I have expressed this even before, but I think when we continue, we need to link it up with other platforms in Africa that are going on right now. There are multiple programs, multiple platforms ongoing right now just regarding COVID and overall the health sector in terms of local production, communication, so many other things: financial support, financial stability, resilience, healthcare system resilience. So there are other platforms even chaired by the African Union and the African CDC and also the ECA. So I think if we can link this platform as part of that or as an extension to that, it would be so much helpful. And also it would serve as an arm to actually implement those recommendations that are put forward on those platforms. That's my only recommendation for this.
Perfect, thanks. I couldn't agree more. Dr. Bayeni expliquait comme quoi il faudrait que on s'associe aux plateformes qui existent déjà en Afrique, qui parlent déjà de production locale, de communautés qui peuvent être une arme externe pour vraiment s'assurer que les recommandations qu'on fait, les discussions soient mises en place. Okay.
Yeah, yes.
Dr.
Yes, I think I agree with Dr. Bennett of that we need to continue, and this will be a forum where we can exchange ideas, which are already doing.
Yes.
And I really want us to focus on the healthcare system, to focus on how to strengthen our healthcare, because of this COVID-19, so many things have actually occurred. We are not even thinking about other health programs again. We have other diseases that are ravaging in the African continent, but we are not really looking at it. We are only focusing on COVID-19. So we shouldn't do focus on that too. Yes. We need to integrate or bring into bear other diseases that we say of public health importance. So we need to bring in UNICEF, WHO, African CDC to be able to strengthen this particular forum that will really beneficial to all the African countries. Thank you very much.
Perfect. Thank you so much. Couldn't agree more with you, Dr. Oladiju, and with you also, Dr. Bayeni, as in we never, and I'm not intending on having this platform as a separate thing, because I completely agree with you in the way that we should maximize what is already done, and also with the fact that it's, and I've always throughout the webinar, that's what we've tried to link as well, as in although we're focusing on COVID-19, we have to focus on our healthcare system, because we have to continue giving care to our populations, which is very important. Dr. Oladejo expliquait que voilà, c'est un type d'initiative qui doit continuer dans l'objectif aussi de toujours l'amélioration de nos systèmes de santé en Afrique, associer les autres maladies et aussi. Je m'entends un écho, Dr. Hamadi. Mais vraiment essayer de focaliser à comment améliorer ces systèmes de santé, ne pas se focaliser que sur le Covid-19, on a déjà ça, mais vraiment continuer et renforcer les initiatives qui existent déjà. Dr. Hamadi, je vais arrêter de parler pour que je ne m'entends pas en écho et je vous donne la parole. So I'll have Dr. Hamadi from Algeria speak now.
Ok, merci. Désolée pour ce problème de connexion, mais je voulais juste remercier tout le monde, et je te remercie particulièrement, Shiraz, par rapport à cette initiative qui me semble très, très intéressante. À mon avis, il vaut mieux, ça serait intéressant de continuer cet échange, mais d'élargir donc mes recommandations sont les suivantes. Désolée pour ce problème de connexion, mais je voulais juste... Il y a un retour. Je voulais juste remercier tout le monde, et je te remercie particulièrement, Shiraz, par rapport sur les suivantes. Désolée pour ce problème de connexion, mais je voulais il y a un retour. Il y a un retour. Bon, ça se répète. Là, je ne sais pas si vous m'entendez. C'est juste pour dire d'élargir à d'autres pays, de choisir des heures hors week-end. Par exemple, choisir 2 heures de temps, c'est largement suffisant. De donner à un pays de présenter une bonne pratique et de laisser plus le temps aux échanges.
Là, je ne sais pas si vous m'entendez. C'est juste pour dire d'élargir à d'autres pays, de choisir des heures hors week-end. Par exemple,
Sorry, I muted myself and I know what you heard, so I'm just going to repeat. I'm sorry. So Dr. Hamadi was thanking you for your presence during this initiative, and as well was saying that it would be good to continue it, but also to extend it to other countries, have it like to do it during the week. I will ask you actually which day would be more feasible for you. After I will send you a poll maybe for that, or if you want to put it in the chat, I will know like this which day would be more feasible for you than the weekend. And what I wanted also to let you know is that among the countries that we, in addition to the countries that we have present today, which are Algeria, Ethiopia, Nigeria, Rwanda, and Ivory Coast, we also have contacts from Senegal that were here with us actually the first session. We are in contact also with South Africa, Kenya, Tunisia, Kenya, Zambia, and Djibouti. So all actually have been contacted and would have wanted to participate. Some actually had some internet problems for today. Some other because it is the weekend actually. So definitely this was something that is thought for the future so that we don't do it during the weekend. I hope maybe Wednesdays or Thursdays would be good for everyone. So that we can continue having these discussions. I am very happy to see that we all want to continue this initiative, and I do believe that yes, we will work. As you've seen today, we have the Africa CDC with us, and I do hope that in the future we'll be able to implicate them also, or at least making sure, as Dr. Bayeni was saying, that we work hand in hand with what is done, strengthening what is already done, and continue together to work on obviously fighting COVID-19 with the best practices, but also improving our healthcare systems in general. So thank you again for participating. Merci beaucoup. Donc, I'm just going to quickly translate what I just said in French for the people who are in French. Donc, en expliquant que parmi les personnes en fait donc les ministères, il faut savoir que d'autres ministères tels que la Côte d'Ivoire, le Sénégal, le Kenya, l'Afrique du Sud, Djibouti ont été contactés, ils veulent faire partie de cette initiative, donc on espère que dans le futur, on les aura avec nous également, que l'on va continuer à les faire, ce sera en semaine, afin de non seulement travailler sur la lutte contre la coronavirus, mais aussi pour améliorer nos systèmes de santé. Merci à vous tous. Thank you everyone for participating. If you have any final word, just let me know. If not, thank you so much for your participation, and I hope to see you very soon. I think we'll give 2-3 weeks before the next meeting, just to have to make sure that we have a good plan and that we will have the initiative organized in the best way possible.
Thank you so much.
Thank you so much, Dr. Biyeni. Yes, Dr.
Thank you so much.
Thank you so much, Dr. Oladijo.
Yes.
Thank you for everyone who followed us today. If you have any question, you don't hesitate. Thank you. Bye. Have a great weekend and thank you so much for following us.
Bye bye.
Merci beaucoup à vous tous. Merci
Merci
d'avoir
beaucoup.
Yes. Thank you so much for everyone.